Hello, everyone. I would like to first just thank Force for the opportunity to come talk today about pancreatic cancer early detection. I'm really excited to be here. My name is Bryson Katona. I'm a gastroenterologist at the University of Pennsylvania, where I serve as the director of the gastrointestinal cancer genetics program. And I also run all of our early detection studies in pancreatic cancer at Penn. These are my disclosures. The only one that is pertinent today is that I did participate in the PanFam study that was run by Immunovia, and I will talk briefly about the results from that study today. So today, what we're going to try to cover is what is the risk of pancreatic cancer, who should undergo pancreatic cancer screening, how do you do pancreatic cancer screening, and then does pancreatic cancer screening actually work? So let's first start talking about what is the risk of pancreatic cancer. But before we get into pancreatic cancer risk, let's just talk about the pancreas first, just to make sure everybody's on the same page here. So the pancreas is a thin organ that basically sits in the middle of your abdomen. It sits just behind the stomach and right underneath the liver, and it sits basically right near the small intestine as well. So there's a lot of important organs and structures that are right around the pancreas. The pancreas is important for digestion. It also is important in endocrine function, specifically for regulating blood glucose through production of insulin. Now, pancreatic cancer itself is actually not a very common cancer. However, it certainly is one of the most deadly cancers. It's currently the fourth most common cause of cancer-related death in both men and women, and probably soon it will become the third most common cause of cancer-related death. However, the lifetime risk of pancreatic cancer in the average risk person is only about 1%. Now, one concerning trend is that pancreatic cancer deaths are actually increasing. So when you look at these multiple different cancers in both males and females, what you can see is that the majority of cancer death rates are actually decreasing. However, pancreatic cancer, which is represented by the orange line in both of these graphs, is actually increasing for both males and females. However, one bright spot about pancreatic cancer treatment is that for stage 1A and stage 1B pancreatic cancer, survival is actually increasing. And what you can see over this decade here is that survival for early stage or stage 1 pancreatic cancer is essentially around 80%. Whereas for stage 2 pancreatic cancer, it's less than 20%, and for stage 3 and 4 pancreatic cancer, 5-year overall survival is less than 10%. So this really indicates that if pancreatic cancer can be caught at an early stage, meaning stage 1, that patients have a much better chance of improved long-term survival. Now, the majority of pancreatic cancer is actually sporadic. And when we say sporadic, we mean that's not related to any familial or genetic risk. However, about 10% of pancreatic cancer is due to either familial risk or inherited cancer predisposition syndromes. So when we think about family history, we know that the pancreatic cancer risk is actually proportional to the number of relatives in the family that have had pancreatic cancer. And so the more close relatives you have, and in this case, these numbers are for first-degree relatives, meaning siblings or parents, the more first-degree relatives you have with pancreatic cancer, the higher an individual's risk of developing pancreatic cancer. And on the right of this slide, you can see that there are many cancer risk syndromes that are also associated with increased risk of pancreatic cancer. And these include genes that are associated with hereditary breast and ovarian cancer, such as BRCA1 and BRCA2, ATM and PALB2, as well as genes associated with Lynch syndrome. There are some other rarer syndromes that are also on this list that are due to mutations in other genes that also increase pancreatic cancer risk. So now let's talk about who should undergo pancreatic cancer screening. And when we think about kind of the average risk general population, this was a statement that was put out by the U.S. Preventative Services Task Force a couple years ago. And basically, this statement recommends against screening for pancreatic cancer in asymptomatic adults. And this really refers to individuals who are at average risk. And so, unlike breast cancer screening and unlike colorectal cancer screening, which are done in all individuals, it's not recommended that pancreatic cancer screening be done in all individuals. However, there are specific subgroups where pancreatic cancer screening is recommended. And one of those would be an individual who fulfilled criteria for familial pancreatic cancer. Now, familial pancreatic cancer is where you have two affected relatives with pancreatic cancer who are directly related to one another, and the patient has to be directly related to one of these two relatives. So, for example, if you had a father and a paternal grandfather, or a father and a sister, those would all be situations of familial pancreatic cancer. And under these circumstances, it would be recommended to start screening around age 50 or 10 years younger than the youngest pancreatic cancer in the family. Now, there are also recommendations for carriers of pancreatic cancer risk genes, including BRCA1 and 2, ATM, PALB2, and genes associated with Lynch syndrome. In this case, what's required to qualify for pancreatic cancer screening is to have a family history of pancreatic cancer in either a first degree or second degree relative. So first degree meaning parent or sibling, second degree relative meaning grandparent or aunt or uncle. And again, it's recommended to start at age 50 or 10 years younger than the youngest pancreatic cancer. And then finally, there are rarer syndromes such as Creutzfeldt-Jaeger syndrome, carriers of a CDKN2A mutation, and individuals with hereditary pancreatitis, where pancreatic cancer screening is recommended really independent of whether or not there is a family history of pancreatic cancer. However, turning back to the mutation carriers, for a mutation carrier in this particular group, BRCA1 or 2, ATM, PALB2, or Lynch syndrome, to qualify for pancreatic cancer screening, really they need a family history of pancreatic cancer in the family. But how about screening mutation carriers without a family history of pancreatic cancer? I think this is an important point because family history can really be impacted by many things. So sometimes individuals will have a very small family size, and in which case there will be fewer patients or people in that family who are at risk for developing pancreatic cancer. Oftentimes, individuals don't know their family history well, or maybe they have incorrect family history, and so they may not know if there is a pancreatic cancer in the family. And certainly when we're talking about genetic cancer risk syndromes, it's possible that individuals may have developed other cancers at earlier ages. And these deaths due to cancers at earlier ages, again, may reduce the number of individuals who are at risk for pancreatic cancer. And then finally, I'll just highlight the point that the majority of pancreatic cancers that actually develop in BRCA1 and 2 carriers and PALB2 carriers and ATM carriers actually occur in the absence of any family history of pancreatic cancer. And so, I'll ask the provocative question, is it right to use family history as eligibility criteria for pancreatic cancer screening for mutation carriers? And so to try to answer this question, we started a study many years ago, back in 2015 now at Penn, where we started offering pancreatic cancer screening to carriers of a BRCA1, BRCA2, PALB2, or ATM mutation who did not have a family history of pancreatic cancer. And we were fortunate to be able to publish the initial results from this study late last year. And really, these results showed that pancreatic cancer screening really can be considered in these individuals without a family history of pancreatic cancer, especially after a careful discussion of the risks and benefits of screening. However, certainly the effectiveness of this screening strategy requires further study. Now, excitingly, after our paper came out, there was a recent guideline update that was issued by the ASGE, or the American Society for Gastrointestinal Endoscopy, that was just published earlier this year. This was a particular guideline focused on pancreatic cancer screening in high-risk individuals. And what this guideline actually came out to say is that, in fact, they noted that all BRCA1 and 2 carriers should be offered pancreatic cancer screening regardless of family history. And so this is a major shift in the guidelines, as previously a family history of pancreatic cancer was always needed for screening. And in fact, this guideline goes on to say that carriers of not just BRCA1 and BRCA2, but also carriers of a PALB2 mutation do not need a family history to be considered for pancreatic cancer screening. For ATM carriers and individuals with Lynch syndrome, it was still recommended that a family history of pancreatic cancer be present before pancreatic cancer screening was offered. But this certainly is an exciting development in the field, and hopefully will allow more individuals access to pancreatic cancer screening moving forward. So next, let's move on to how do you actually do pancreatic cancer screening? And before I get into how you do it, I think I want to spend a little bit of time talking about what makes for a good pancreatic cancer screening test. And so really a good pancreatic cancer screening test should allow for an earlier detection of either a cancer or a precancer. So as an analogy, like for a colonoscopy, for example, colonoscopies allow us to identify colon polyps, which are precancerous lesions, and allow us to remove those polyps. And so for pancreatic cancer, really we want the test to allow for earlier detection of a cancer or a precancer. We also need to be able to intervene because of finding this lesion earlier. And so if you find it but can't do anything about it, that's not helpful. You need to be able to do something about this lesion that you find at an earlier time. Next, we also want to make sure that individuals have improved survival from pancreatic cancer. And so, again, if you find a pancreatic cancer a year earlier, but then everybody still succumbs to the cancer at the same time, that's not an effective screening strategy. Really, screening needs to improve survival from the cancer. We also want this test to not create more harm than good. So for example, if a screening test would harm 10 people for every one person it helped, that also would not be an ideal test. And then finally, the test should be cost effective. So taking all that into account, how do we actually do pancreatic cancer screening? Well, I'll tell you about three parts. We'll talk about imaging, we'll talk about blood work, and then we'll talk about enrollment in pancreatic cancer screening studies. Now, as far as imaging, this is really the cornerstone of pancreatic cancer screening. And imaging should be performed on at least a yearly basis in all individuals who are at increased risk for pancreatic cancer. And although there have been some studies looking at using CT scans or abdominal ultrasounds, these modalities are really not recommended imaging modalities for screening for pancreatic cancer. And instead, we rely on an MRI of the abdomen or something called an EUS or an endoscopic ultrasound. Now, most people are probably familiar with an MRI, as you can see in the top right of this slide. An MRI of the pancreas basically screens the middle of your abdomen. You lay on this little backboard here and go into a scanner, and it takes about 30 minutes or so to get good images of the pancreas. Now, an endoscopic ultrasound is something that people may not be as familiar with. This is where an upper endoscopy is performed, where a thin camera, while under anesthesia, is inserted into the mouth and is passed down into the stomach, as you see on the bottom right there. The stomach and the pancreas are next door neighbors, and so by putting the camera into the stomach, it affords a very up close and personal look of the pancreas. Now, some individuals, in terms of what imaging modality is performed, don't like anesthesia, and so they get MRIs every year. Other individuals can't tolerate MRIs, and so they get an endoscopic ultrasound every year, while other individuals will alternate back and forth between MRI and endoscopic ultrasound. I think either of those patterns is fine. The most important thing is that the imaging actually gets done. Now, let's go through some of the pros and cons of MRI and endoscopic ultrasound. So MRI, really the pros of MRI is that it's a non-invasive test. MRIs are also better for detection of pancreatic cysts, which are small little fluid-filled cavities in the pancreas that account for about a third of all pancreatic cancers. Now, the cons of MRI are that if a lesion is found, you ultimately need an endoscopic ultrasound to allow sampling of that lesion. The MRI also utilizes gadolinium, and there's some concern about long-term gadolinium exposure. And cons for both the MRI and the endoscopic ultrasound is that there's a high rate of incidental findings. And so we find things in the pancreas in about 30% of patients. Most of these findings don't have any clinical relevance, but you just have to prepare people that their report may come back not totally normal. And certainly the test is expensive as well. As far as endoscopic ultrasound, the real pro of endoscopic ultrasound is that it allows for sampling of any lesion that is detected in the pancreas, all during the same procedure. It's also better for detecting solid lesions of the pancreas, which we think account for at least about 2/3 of pancreatic cancers. The con is that it's invasive and requires sedation, and certainly there's some expertise dependence to that procedure as well. Now, moving on to blood work. This has been an area of a lot of active research. However, at this point, we have, unfortunately, very little that we actively use in terms of blood tests for screening for pancreatic cancer. The one that I get asked about the most commonly is something called a CA19-9. This is a blood-based marker for pancreatic cancer that has a lot of utility once you're diagnosed with pancreatic cancer, but at this point alone does not serve as a good standalone screening test for pancreatic cancer. It's also, well, I'll spend a little bit of time talking about diabetes as well as some other newer tests that are out on the market. Let's talk about the data on diabetes first. And this has been an area where there's been a lot of exciting data over the last several years that's shown that in a small proportion of patients who develop a new onset pancreatic cancer, there's actually evidence of either diabetes or prediabetes in the 3 years leading up to the diagnosis of pancreatic cancer, such that this prediabetes or diabetes could be the very first sign that a new pancreatic cancer is actually developing. And so in my patients who are at high risk for pancreatic cancer, what I do is actually do yearly assessment of either a fasting blood glucose or a hemoglobin A1C. And if an individual were to develop increases in their blood glucose or to develop diabetes or prediabetes, I would actually then consider imaging their pancreas every 6 months instead of every year. And although this particular recommendation has not made it into the formal guidelines yet, I know this particular practice is followed by many physicians who specialize in pancreatic cancer early detection. Let's talk about some of the other blood tests that are out on the market. There have been two different multi-cancer detection tests that are out on the market. These are basically blood tests that don't just look for one cancer, but they look for a whole spectrum of different cancers. And one of these tests is called the Gallery test, and this is from a company called Grail. And the other one is called the Cancer Seek test, and this is from a company called Thrive. Now, these are interesting tests to look for many different cancers. However, when you look at how they perform for pancreatic cancer, especially early stage pancreatic cancer, they don't perform all that well. So they're very good at detecting late stage pancreatic cancer. But as far as screening goes, really we need a test that detects early stage pancreatic cancer. And so I don't think that at this point, that these multi-cancer detection tests have a role in pancreatic cancer early detection in high-risk individuals, at least at this point. There's one other test that I do want to mention, and this is the IMMray PanCan-D test. This is from a company called Immunovia. This test is also commercially available. However, unlike the prior two tests, this test is really only focused on the pancreas. And what it is it's a blood sample that is run on this complex platform to look for multiple different markers of pancreatic cancer. And then it's either reported to be positive, negative, or borderline. And some preliminary results from testing of this particular test on a large cohort of different pancreatic cancer stages showed that this particular test did have a fairly high sensitivity for early stage pancreatic cancer. And so it seemed to perform better for stage 1 and stage 2 pancreatic cancers compared to some of the prior tests that I showed you. Now, this test was utilized in a large international study called the PanFAM study, which wrapped up recruitment about a year or two ago. In the PanFAM study, there weren't enough patients who developed pancreatic cancer while on study. And so the study was not able to validate how this test worked in kind of a prospective manner. However, certainly there will be more work on the IMMray PanCan-d test moving forward to see if it potentially could be intertwined into what we're doing already for pancreatic cancer early detection for high-risk individuals. Lastly, I just want to also talk about enrollment in pancreatic cancer screening studies. And basically, any patient that I see in clinic who's going to start pancreatic cancer screening, I strongly encourage them to enroll in one or if not multiple pancreatic cancer screening studies, because this is an area where we really need more data and more information. And so I'll highlight just two studies that we're recruiting for at Penn, but that are also recruiting at multiple sites throughout the country. One is the CAPS-5 study. This is a study that has 8 centers across the US. It is funded by the National Cancer Institute, and we're now entering our 7th year of recruitment into this particular study. And I'll show you some of the really promising data that was generated from this CAPS-5 study a little bit later in this talk. The other is the PROCEED Consortium, or the Pancreatic Cancer Early Detection Consortium. This is a larger study, and it's not just confined to the United States. There are also centers internationally as well, and there are about 35 centers that are recruiting to the PROCEED Consortium. And so I do think that individuals who undergo pancreatic cancer screening, that enrollment and involvement in these studies is incredibly important. So in the last few minutes, let me try to answer the question about, does pancreatic cancer screening work? So when we think about does screening work, I think the most important thing to think about first is, what outcome do we actually want from pancreatic cancer screening? Well, one, we want to make sure that we're detecting these pancreatic cancers at earlier stages. We also want to make sure that patients who are involved in screening are surviving longer after a diagnosis of pancreatic cancer. And of course, we also want to minimize harm. And when we think about harm related to pancreatic cancer screening, really the biggest harm that we have the potential to induce is an unnecessary surgery for something that's concerning for pancreatic cancer. However, once the surgery is done and the specimen is examined, turns out to not be a pancreatic cancer or not be a high-risk pancreatic lesion. So I'm going to highlight 2 studies that were both published within this last year that I think are incredibly important studies. The first one is a report from the International Cancer of the Pancreas Screening Consortium. This is an international cohort of high-risk centers that followed over 2,500 high-risk individuals who are undergoing pancreatic cancer screening. In this particular consortium, they found that 28 of these individuals actually progressed to pancreatic cancer or a high-risk lesion while they were getting screened. However, unfortunately, 50% of these patients had presented with a new lesion that wasn't seen on a prior imaging, and they presented at a very short interval, at a median of only 11 months since their prior imaging test. And unfortunately, about 3/4 of these patients had progressed beyond the pancreas. Now, this particular study doesn't paint a great picture of the effectiveness of pancreatic cancer screening. However, I think the important things to note are that this study really was an international study, and so results that we may get from United States data may be different compared to the international populations. And so on that note, I do want to highlight the other big paper that was published this year, and this was data from the CAPS-5 study. The CAPS-5 study, again, is the National Cancer Institute funded study looking at screening of individuals who are at high risk for pancreatic cancer. And this particular paper looked at data from the CAPS-1 all the way up through the CAPS-5 study, looking at about 1,700 high-risk individuals who were undergoing pancreatic cancer screening. And what this study showed was that if you compare those individuals getting screened compared to those individuals not getting screened, you see a major difference in the stage at which the pancreatic cancers were detected. So if you look on the left here, the individuals who were getting screened, only about 5% of these individuals presented with stage 4 disease or metastatic pancreatic cancer, where if you look at the individuals who were not getting actively screened, what you can see there is that over 80% of individuals presented with unresectable metastatic stage 4 pancreatic cancer. So just a remarkable difference in downstaging of pancreatic cancer with screening. And of course, downstaging is only important if people live longer and survive longer because of it. And that's exactly what was seen in this particular study. So if you look at the median overall survival, meaning the amount of time that people live after their initial diagnosis of pancreatic cancer, for those individuals who were getting screened, the median overall survival was almost 10 years, compared to those who are not getting screened, where the median overall survival was only 1.5 years. So again, very, very disparate survival between those getting screened and those not getting screened. And so I think this particular study was incredibly promising for the field and showed that if you do pancreatic cancer screening in high-risk individuals, you can identify cancers at earlier stages, and people ultimately live longer because of that identification. So hopefully today I provided a good overview of the risk of pancreatic cancer, who should undergo screening, how should screening be done, and does pancreatic cancer screening work? And I want to just leave you with a few take-home points. First is that pancreatic cancer screening really should be considered in high-risk patients who are eligible for screening. However, I think it's important that patients also have a discussion about the risks, benefits, and limitations of pancreatic cancer screening. Second is that pancreatic cancer screening should always include at least annual imaging of the pancreas, and this should be done with either an MRI or an endoscopic ultrasound. And although not guideline recommended yet, my practice is at least an annual assessment for diabetes. Third, I think that all individuals undergoing pancreatic cancer screening should also be ideally enrolled in a clinical study. And I think this will be so important for helping us advance our knowledge in the field and ultimately improve our ability to perform pancreatic cancer screening. And then fourth, I'll say we definitely still need more research in the field. Some areas that really need research include what are the optimal screening strategies. We need blood-based tests that can be utilized in pancreatic cancer screening. We need to improve our imaging technology to enhance our ability to detect early pancreatic cancers. And we also need to do a better job of risk stratifying and really focusing in on those individuals who are at the highest risk of pancreatic cancer and focusing in on that subgroup to do our screening. So thank you so much for your time and attention. And hopefully we have answered some questions real time during this talk, but I hope that you all enjoyed it, and I hope you enjoy the rest of the FORCE meeting. Thank you very much.